Good morning, everyone. First of all, I wanted to say a big thank you to Dr. Puri and the entire Fortis group for giving me the opportunity to speak at this meeting. It's a great pleasure for me to be here, back home where I belong. This is a picture of the University of Maryland where I work. On the left-hand side, you can see the University of Maryland Medical Center, and on the right-hand side is part of the medical school building, Devidge Hall, which is of some historical significance. Not as old as our buildings in India are, but it was built in 1812 and has been the one medical institution building that has been in continuous use for medical education since it was first started. Today I'm going to talk about the anesthetic management of minimally invasive robotically assisted cardiac surgery with a specific focus on robotically assisted totally endoscopic coronary artery bypass, or TCAB as we call it. The TCAB essentially represents the ultimate innovation, I should say, in minimally invasive heart surgery, allowing the surgeon to perform coronary anastomosis in a completely closed chest setting with minimal incisions with the help of robotic technology. Now, robotic technology, since it first began in the 1990s, has come a long way since then. Met and colleagues performed the first TCAB operation in 1998 at the University of Paris, and it has now become a pretty reproducible technique which is performed at many centers across the world. What was initially started as a one-vessel coronary artery bypass has now gone to triple-vessel bypass in the arrested and beating heart setting, and there are even quadruple vessel bypasses now being performed, but not yet reported in the literature. So how does this change things for the anesthesiologist? Clearly, any application of new technology brings its challenges, and definitely the application of robotic technology not only presents unique challenges to the anesthesiologist, but to the entire team of people. So what is really different about this from traditional open cases? Well, a lot of things, as I'm going to talk about this for the next 30 minutes. What Dr. Mishra and Dr. Lair mentioned, of course, was the application of remote perfusion strategies for cardiopulmonary bypass. The more the number of catheters that we use, the more intense the imaging has to be in order to make sure that we can do what is best for the patient. This requires intensive use of intraoperative TEE, and you need an anesthesiologist who's experienced in TEE. In addition, you have all the physiological demands of one-lung ventilation which are required to create a working space, as well as CO2 insufflation into the operative side of the chest, which can make matters quite dicey, as we'll see later in the talk. And in addition, a complete change from the traditional operative model of the surgeon working next to the patient. Here the surgeon is going to be sitting away from the patient working at the console. Of special mention is the fact that at least initially in the procedure, during the initial part of the learning curve, we have long operative times, and also the fact that we have very limited access to the patient once the robot gets docked, especially the airway. I'm going to cover some of these in detail in the later on slides. Now, what does this translate into? Teamwork. That's all I can say. It is teamwork, intense teamwork. There is a greater need for communication and teamwork in this setting than in the open cases. Bonardi and colleagues have shown a definite reduction in operative room times after establishment of a dedicated, consistent team, and have also shown that the key to the establishment of a successful robotics program in any institution is establishing a dedicated, consistent team. You work with the same people, same thing, you communicate effectively, and then you can achieve results. So for any good anesthetic management, of course, it's important to have an overview of the surgical procedure, to know the tools, know the techniques, and know the sequence of events. Dr. Mishra and Dr. Lair covered part of it. The Da Vinci robotic system is currently the only surgical system in use suitable for TCAB right now. It has three main parts: the surgeon console, where the surgeon is seated away from the patient and operates the surgical instruments which are on the patient card. And then there's a third one called the video card, which basically contains a 2D monitor for the rest of the operative team to view the procedure, as well as a CO2 insufflator and a light source. And you can see that in this picture here. The surgeon console on the left side, the instrument, the patient cart with instrument arms in the middle, and the video cart on the right side. And this is a picture of the robot in action, where you can see the instrument arms and also the cannulation side. Being good at video games is actually a significant advantage for the robotic cardiac surgeon, as you can see in this next cartoon here. is definitely, I can say, a good advantage because that's what it appears like the surgeon is doing, but I'm sure it's a lot more than that. So what are the different varieties of how robotically assisted TCAP can be done? Well, I'm going to talk about just the totally endoscopic version from the beginning to the anastomosis. And of course, it can be performed on the arrested heart or on the beating heart. And the one on the beating heart can be performed either off bypass or with cardiopulmonary bypass support. Our surgeons at the University of Maryland perform beating heart TCABs with what we call prophylactic or preemptive cannulation for bypass. And the reason for this, and we only do that, we feel it gives us an additional safety measure because we know for sure that emergency conversion in the endoscopic setting, in a robotic setting, is much more difficult than in the traditional open setting. Here you have to undock the robot, move it out, get cannulated emergently in the femoral vessels, which leads to a significant delay in cannulation and can obviously impair patient safety to a great deal. So as anesthesiologists, what are the factors that we need to focus on the preoperative evaluation? Of course, a regular standard workup for coronary artery bypass is mandatory. We have to focus on what are the factors that would we look at things, what are the factors that will impair single lung ventilation, because these patients are subjected to prolonged single lung ventilation, especially early on in the learning curve. Then from the surgical perspective, what would hamper surgical entry into the pleural space, or what would make it a contraindication? And importantly, like Dr. Lair and Dr. Mishra mentioned again, very important in minimally invasive and robotic cases, what will affect cannulation for remote access perfusion? And here is a table which shows some of the factors and what we can do to rule these things out. Obviously, any patient having severe COPD, severe pulmonary hypertension, or any other lung disease, those conditions would significantly impair the ability to tolerate one lung ventilation and are relative contraindications to this procedure. How should we work them up? Well, obviously, starting with the functional capacity is a good way. Are they able to climb flights of stairs or not? Is their functional capacity greater than 4 metabolic equivalents or not? Pulmonary function tests are very useful for assessing the degree of lung disease. And we routinely perform PFTs in all our patients undergoing robotic minimally invasive surgery. Chest X-ray is useful to give some idea of some local process or anything else going on that might affect ability to tolerate one lung ventilation. And of course, in patients who already have some degree of COPD, blood gas on room air is a useful guide to tell us if the patient has some hypoxia or resting hypercarbia, because there are going to be significant changes on during CO2 insufflation that would definitely make a big difference. From the surgical point of view, of course, ruling out extensive pleural adhesions, the patient having previous cardiac-thoracic surgery definitely would be a relative contraindication to this procedure. This can be ruled out on a chest X-ray or a CT scan of the chest. Conditions like narrow intercostal spaces, cardiomegaly, make it difficult for the surgeon because they make the working space very narrow. And again, like I said, can be picked up on these tests. So a CT angiogram of the chest, abdomen, and pelvis is very useful to quantify the degree of atherosclerosis or to find out what's going on in the peripheral vasculature, and importantly also to get an idea about the arterial and the venous anatomy. And pick up conditions such as excessive tortuosity of the aorta, presence of aneurysms, if any, and look at the diameter of the femoral vessels. Like Dr. Mishra was saying, narrow femoral vessels is a big problem for cannulation, especially with the big femoral cannula that we use, since the endoaortic balloon is passed through the femoral arterial cannula. Preoperative echocardiography is another tool to assess the degree of atherosclerosis, look for aortic aneurysms, and of course, a standard Doppler ultrasound to rule out any carotid or subclavian stenosis. The preoperative echocardiography also would rule out severe valvular abnormalities such as aortic insufficiency or significant aortic valve calcification, which are again contraindications to use of the endoaortic balloon clamp. Okay, I'm going to touch a little bit upon the remote access perfusion. Hopefully won't bore you with too many details since you've already seen this, but again, they cannot emphasize enough that the foundation for successful minimally invasive and robotic surgery is successful remote access perfusion, no doubt about that. And again, how do we as anesthesiologists play an important role? Like I said, transesophageal echocardiography is key to successful, safe placement of these cannulae. So again, like was talked about before, the remote access perfusion system involves typically femoral, arterial cannulae, and in event of significant femoral disease or peripheral vascular disease, the axillary artery is used as an alternative cannulation site. The other components are the pulmonary artery vent, a coronary sinus catheter, both of which are inserted percutaneously by the anesthesiologist, and lastly, the endoaortic occlusion balloon catheter, which is inserted again percutaneously by the surgeon through the side arm of the arterial cannula. Like I said before, again, visualization is key to reducing complications in these patients, typically done with TE. Fluoroscopy is occasionally used as an option, but we have not had any issues. We've pretty much imaged all our patients with TE, intraoperative TE. So like I said again before, most commonly the femoral approach, you can occasionally use the axillary artery in patients who have significant peripheral vascular disease. Oops, misbehaving. Typically a 21 or 23 French remote access cannula with the side arm is inserted into the femoral artery. The one thing our surgeons, I think, do a little bit differently is they also insert a distal leg perfusion catheter because of the fact that there is concern that these large cannulas that use for cardiopulmonary bypass in the femoral vessels cause the risk of leg ischemia, especially with prolonged cannulation. So a distal, and I'm going to show that in the picture to follow, but an 8 French cannula is placed which perfuses the leg distally. This is an artist's depiction of an arrested heart, robot-assisted arrested heart TCAB, and you can see 1 through 5 are the robot, are the ports for the robot arms, and you can see the venous arterial cannulation in the groin, and D is the distal arterial distal leg perfusion cannula. The second component is the pulmonary artery vent, which is modified, I should say, a specially built pulmonary artery catheter. It's extremely soft. It is percutaneously inserted, commonly through the right internal jugular vein by the anesthesiologist through a standard 9 French introducer or multi-lumen catheter, and inserted and placed in the proximal pulmonary artery. Now, it does monitor routinely pulmonary artery pressures, but the most important function of this is to augment the venous drainage, assist in decompression of the heart, and basically function as a pulmonary artery vent, like the name says. A thing for anesthesiologists to note is that this is a non-heparin coated catheter, just like the coronary sinus catheter, and once the catheter is being inserted, we typically give 5,000 units of heparin to prevent the formation of clots on this catheter. And at the end of the procedure, we don't leave these catheters in. These are pulled out at the end of the case and replaced with a pulmonary artery catheter if required. This is a still image, a 2D TE view showing the presence of the double lines, the pulmonary, and also actually the presence of the coronary sinus catheter in the coronary sinus. This is another view, what we call an ascending aortic short axis view. What you see here is the proximal pulmonary artery here with the pulmonary artery vent, and then the right pulmonary artery here, and also a very nice view of the cross-section of the aorta here with an inflated endoaortic balloon in the aorta. The next catheter is, it is inserted when there is a need for retrograde cardioplegia in these procedures as an adjunct to enhance myocardial protection when we anticipate that a long cross-clamp period is expected, such as early in the learning curve, or when there are multiple ungrafted territories, such as in hybrid procedures. This is a modified bicable view. On this, let me get this pointer to work. On the top, you can see the left atrium. On the top, you see the left atrium here, and the right atrium, has all 3 cannulae in it. You can see the coronary sinus catheter and the pulmonary artery catheter that are labeled, and the venous cannula right below that. That is inserted by the surgeon through the femoral artery all the way up into the ascending aorta, and you can see this here. I know this has been shown in the earlier talks, but when the balloon is inflated, it functions as an intra-aortic cross-clamp and occludes the ascending aorta. And you can see here on this TE view, the left atrium, the left ventricular outflow tract, the aortic valve, and this is the ascending aorta and the endoaortic balloon, which is actually all the way up to the valve. When it gets inflated, it actually gets pulled back, and the optimal position for this catheter is just above the level of the sinotubular junction in the ascending aorta. As you can see in this picture here, this is the aortic valve, ascending aorta, this is the sinotubular junction, and this is the edge of the endoballoon. So the tip of this catheter, and you can see this switch through the valve, but the left atrium, left ventricle, and the ascending aorta right here. This is a quick sort of busy slide, but showing basically the different steps, sequence of events of the surgical procedure in robotic arrested heart TCAB, and I'm not going to dwell too long on this. In addition, the CO2 insufflation that occurs leads to significant changes. I'm going to talk a little bit about that. But you have increased introthoracic pressure and also reduced systemic venous return. So there's a potential for significant hemodynamic instability when you combine all these techniques. There are no published studies, no data on the use of regional techniques in TCAP surgery in patients with full systemic heparinization. But of course, I think regional anesthesia definitely has a role to play in beating heart procedures that do not require full anticoagulation. So what is different about intraoperative monitoring in these procedures compared to standard procedures? A few different change of things with regards to standard monitors. ECG monitoring can be very suboptimal. The ECG leads need to be placed lateral and posterior to the mid-axillary line in order to avoid the board placement sites. So that definitely confounds the interpretation of ischemia. And also the initiation of capnothorax definitely changes the electrical axis and amplitude of the ECG of regional wall motion abnormalities, and that definitely serves as a useful tool when ECG, especially the ECG, is a confounding factor. Again, arterial lines, Dr. Mishra touched on this in his talk, when the endoaortic balloon clamp is used, which is pretty much what we use exclusively for our arrested heart TCABs, we insert bilateral upper extremity arterial lines in order to be able to monitor the proper position of the endoaortic balloon clamp. A reduction in the right side on the left is typically seen when the endoaortic balloon when the balloon migrates distally and occludes the origin of the brachiocephalic trunk. And if it migrates further distally and occludes the origin of the left subclavian artery, then you can see a drop in the left pressure compared to the right. And here is a picture showing the comparison. The right is the red and the left side is the white. And you can see that the pressures are very, very close on cardiopulmonary bypass. And on the right side, you see a reduction in the pressure on the right side due to occlusion by the endoaortic balloon. And for beating heart procedures, a single upper extremity A-line is usually more than sufficient. So in the use of cerebral oximetry in cardiac surgery has definitely gained acceptance in a lot of centers. The overall use remains a little bit controversial. There's different practitioners who believe in different theories, but it definitely has a role to play in monitoring endoaortic balloon placement. And similar to the arterial waveforms, a drop in the oximeter reading on the right side could indicate occlusion of the innominate artery orifice, and a drop on the left side could indicate occlusion of the left common carotid. So if there's a significant decrease or sudden drop in the cerebral oximetry reading on one side, it should prompt an evaluation of the balloon position. The same technology that we use to monitor the cerebral oximeter readings, which is near-infrared spectroscopy, we have taken that to monitor distal the perfusion of the lower extremities. Like I said again before, there's a risk even with the distal leg perfusion cannula of ischemia to the leg. And insertion of that leg perfusion line is helpful, but we have detected kinks in the distal leg catheter on occasion by use of the nurse technology. What we typically do is we use the cerebral oximeter sensors and we put it on the calf muscles. We obtain baseline values at the beginning of the case, and then we monitor trends throughout the procedure. If there's a significant unilateral 20% drop on that side, then we explore the leg cannulation site, and it's usually on the site that the femoral cannula is inserted. Intraoperative management, again, no controlled randomized trials about one anesthetic technique over another in TCAB. Our standard practice is to do a standard general anesthetic technique where we induce our patients with etomidate or propofol, fentanyl, rocuronium, midazolam, and then maintain with routine inhaled anesthetics and intermittent doses of narcotics and muscle relaxants. The important thing is that it is very important when the robot arms are in the patient to maintain muscle relaxation, because any sudden patient movement could lead to significant great vessel injury and patient harm, obviously. So coming to one of the big challenges for anesthesiologists is the ability to provide significant one-lung ventilation in view of the fact that there's going to be capnothorax added on top of that. One-lung ventilation is achieved by the standard methods. The commonest method used is a double lumen endotracheal tube, usually inserted on the left side. Other methods alternatives are a single lumen endotracheal tube with a bronchial blocker on the left side, or a univent tube, which is a different kind of an endotracheal tube, but it has a built-in bronchial blocker on the outside. And there was an interesting technique described in the literature where Ender and colleagues, as an alternative to lung ventilation with a double lumen tube, they described this technique of a single lumen tube being inserted and high frequency jet ventilation, they actually found that it was tolerated quite well, except for the higher PaCO2 levels that were associated intraoperatively. So this is just as a backup. We have no experience with this technique. We have managed to successfully isolate the lung, usually with a double lumen tube or rarely with a bronchial blocker. Another big part of the procedure is insufflation. It is an absolutely critical phase because of the immense changes that occur during this phase, and again, warrants very close communication between the anesthesia and the surgical teams. What are the consequences? In this table here, starting with the potential for lung injury right at camera port placement. So the camera port is inserted in the left fifth intercostal space in the anterior axillary line typically, and the presence of the lung in that space can cause again potential for lung injury on that side. So typically we collapse the left lung just prior to the surgeon inserting the camera port. Now in patients who have some COPD, hyperinflated lungs, or any kind of localized bullous disease, it's very helpful to actually disconnect the entire circuit so you have movement of the lungs and the heart away from the insertion of the camera port side. So once the camera port is inserted, the surgeon starts insufflating carbon dioxide, which is typically insufflated to pressures of 10 to 12 millimeters of mercury. During this period, especially in the patient, if you're doing this as a second case or in someone who has been NPO for a prolonged period of time, you can see significant hypotension. Now, we can circumvent this by giving them a fluid bolus prior to that, especially if we know that the patient has been hypovolemic for a period of time. But once it occurs too, we generally, first line treatment is the fluid bolus and temporize with vasopressors. And then in case it doesn't get better, we typically ask the surgeons to reduce the insufflation pressure a little bit. And then, usually with a combination of the pressors, the fluid bolus, and reduction in insufflation pressure, usually we manage to, this period passes, and then, things settle down. Now, in patients with poor ventricular function, initially when TGAPs were started, poor left ventricular function was a contraindication to doing this procedure. Contraindications have continuously been evolving and things have been changing. Yes, in patients who have somewhat reduced left ventricular function, the use of an intra-aortic balloon pump or addition of inotropes definitely can be management strategies to be considered, and we have done that. What changes for us ventilator-wise? Well, of course, as soon as we go on one lung ventilation, typically you see this increase in peak inspiratory pressures, a reduction in the tidal volumes, and frequently leading to hypoxia and hypercarbia sometimes. But again, once this occurs, we typically we do standard one lung ventilation settings, about 5 to 7 mLs per kilo body weight tidal volume. And then after that, it's a question of manipulating the ventilator settings to keep the tidal volumes at levels acceptable for one lung ventilation, and yet at the same time, increase the respiratory rate and improve minute ventilation so that the patients don't get hypoxic. A lot of the times we have to resort to pressure control ventilation, especially once the CO2 starts getting added. Now, addition of CO2 tends to further, a lot of times, increase the peak pressures further and reduce the tidal volumes again. So at that point in time, again, if the patients get hypoxic, we typically switch to 100% FiO2 for a period of time, increase the PEEP. And one thing that we have seen, we managed to do successfully is convert to two lung ventilation at points in the procedure when the surgeon does not require one lung ventilation, such as when they're taking the mammary down. We switch to two lung ventilation and actually do it at lower tidal volumes and a higher rate. And we avoid hypoxemia, and we also avoid a prolonged period on one lung ventilation this way. And in patients who are absolutely unable to tolerate one lung ventilation, we have to consider the use of cardiopulmonary bypass. Typically, again, because of the increased intrathoracic pressure, we will see this elevation of the CVP and the pulmonary artery pressures, which also tend to go up because there is right heart strain because of the hypoxia and the hypercarbia. There is also a certain amount of right heart strain from direct compression of the right heart due to the increased intrathoracic pressure. And again, treating the cause and use of inotropes if required is something to be considered. We typically look at the CVP PA pressures pre-insufflation, look at it post-insufflation, and then watch trends throughout the procedure. Like I said again, TE, I cannot say enough as a cardiac anesthesiologist about TE. It is vital for the safety of cardiopulmonary bypass procedures and requires supervision even during cardiopulmonary bypass. This is just an overview of the different areas that the TE can be very useful in, and I'm going to go ahead to the next slide and cover these in detail. a good comprehensive TE exam by the anesthesiologist might pick out certain contraindications that were not picked up earlier. We have actually picked up certain things that have changed the surgical plan entirely. We picked up severe mitral regurgitation that was missed before, that the surgeon converted the procedure to an open. So yes, we can make a difference picking out these things. On occasion, like I said, there have been contraindications to the use of the endoaortic balloon, such as severe AI and aortic valve calcification. And in those situations, the decision has been made to switch to a beating heart procedure. Again, of utmost importance, very useful for the safe positioning of cannulae and catheters. So this is the same picture that I showed you earlier of all three catheters in the right atrium. And then the next step after insertion of the coronary sinus catheters in the pulmonary artery vent, actually let me just go back, is when the surgeon starts inserting the guide wire into the right atrium under echocardiographic guidance. Let me just make sure that this plays. This is what we call a modified bicable view with the SVC here, the IVC here, the left atrium and the right atrium. And you can see the pulmonary artery vent shown by the double arrows, and this is the guide wire that's coming in through the IVC all the way up to the SVC. As anesthesiologists, it's very important for us to make sure that this wire goes all the way up into the SVC, because if this does not, then the cannula is not going to follow the course, and also runs the risk of perforation of the right atrium or the SVC rupture that has been documented in the literature in other minimally invasive cases. After the wire is inserted into the SVC, the surgeon follows with the venous cannula. Again, and you can see this venous cannula going up all the way into the SVC. This is a 3D image, again, of the right atrium here, showing the presence of the venous cannula. And the reason why this cannula has to be put up all the way into the SVC is you see these areas or these fenestrations in the cannula that basically are required to be all the way up and effectively drain the SVC, the right atrium, and the IVC. The next step again is visualization of the guide wire in the descending aorta for insertion of the femoral arterial cannula. The surgeon then inserts the femoral arterial cannula, and then this is followed by insertion of the guide wire for the endoaortic occlusion balloon. This is a 3D image of the ascending aorta again, aortic valve right here. And once the guide wire is inserted for the endoaortic occlusion balloon into the femoral artery, it is sent up all the way into the ascending aorta. And actually here, you can see it touching the aortic valve. This wire usually, it gets pulled back once the endoaortic balloon is inserted into the ascending aorta, and you can see that here. Again, the 3D image of the ascending aorta here, and you can see the endoaortic balloon right here in its non-inflated state. This is another 2D image showing optimal positioning of this very close to the sinotubular junction. Another one showing inflation of the endoaortic occlusion balloon in the ascending aorta. And again, infusion of antegrade cardioplegia. So not only is it important for insertion, we use the TE intraoperatively on bypass to monitor the accurate position. Now, TE by itself is not necessarily the only way that you can monitor this. Sometimes you can see the endoaortic balloon disappear from view in the ascending aorta, but you may not have occlusion of the right. So the combination of bilateral arterial waveforms and aortic balloon and use of TE for monitoring position is what is really optimal to ensure that it doesn't migrate too distal. In addition to all these, this is very useful in monitoring the right ventricular dysfunction that we can usually see because of hypoxia, hypercarbia, and then the increased intrathoracic pressure. So TE is very useful in monitoring RV function, as well as in the monitoring of wall motion abnormalities, which can occur on target vessel occlusion in beating heart TCAB. Other functions of TE, monitoring the volume status, assessing general function of the heart, and again, very important, in the post-bypass TE, we look for improvement in the wall motion abnormalities and ruling out complications from the endoaortic balloon, such as aortic dissection. We have had no complications. In the older literature, there was reports of aortic dissection from the endoaortic balloon, which I think subsequently with the newer versions of that, it has gotten better. Any other special considerations? Yes, definitely. A few of the other challenges. Management of ventricular fibrillation in a closed chest setting can be very challenging. Obviously, internal defibrillation is not possible, so as a result, we put external defibrillator pads, but they are very suboptimal in position because you have to allow the chest to be prepped for sternotomy, you have to allow the port sides to be prepped. So what happens is, even if you defibrillate, it may not be very effective. And again, the addition of a capnothorax definitely insulates the heart from the defibrillation current. So what do we do as a result? Well, we attempt alternative therapies prior to attempting external defibrillation. We found that using antiarrhythmic agents such as amiodarone is a first-line method. And then in case that doesn't work, we typically reinflate the endoaortic balloon, give cardioplegia, antegrade cardioplegia, adenosine, and rearrest the heart. And then, once the heart is arrested, the endoaortic balloon is deflated slowly, and the heart usually returns to a stable rhythm. We found that in a significant number of cases. Now, on the rare occasion that we do need to defibrillate these patients externally, it is very important, obviously, to remove the robot, to remove all the instruments from the thorax, evacuate the pneumothorax, and resume two-lung ventilation before attempting defibrillation, because you want to optimize the conditions as much as you possibly can. In the beating heart setting, very difficult managing ventricular fibrillation. And that is the reason why, again, our team believes that having the prophylactic cannulation ready to go on bypass is a life-saving measure in event of refractory ventricular fibrillation. As always, the anesthesiology and surgical team should always be prepared for conversion to an open sternotomy procedure if required. And moving on to postoperative conditions, postoperative considerations, standard post-CABG care, except for the fact that post-sternotomy precautions are not required. These patients definitely have earlier return to normal function, earlier return to activities. In patients with short operative times, such as single vessel TCAB, once the initial learning curve is over, early extubation is definitely feasible, either on the table, in the operating room, or within a few hours in the intensive care unit. But early extubation obviously requires effective post-operative pain management. I talked about epidurals and paravertebral blocks in patients who do not require full anticoagulation. Our surgeons typically insert intercostal blocks, which help supplement analgesia and prevents excessive sedation with narcotics. Of course, standard IV narcotic analgesics as a continuous infusion. The use of alpha-2 agonists, actually, this has significant promise in minimally invasive cardiac surgery, supplemented with low-dose, short-acting narcotics, and the use of non-steroidal anti-inflammatory medications such as ketorolac, if possible. One complication that I wanted to quickly mention is acute lung injury that we have seen in some cases. It is a devastating complication following minimally invasive and robotic cardiac surgery, and it's been rare and poorly described in the literature. In our experience in a combined two-center experience of 659 minimally invasive and robotic cases, the incidence of severe unilateral lung injury was 0.6%. Again, the postulation is that it is ischemia-reperfusion injury of the lung, and no one really knows exactly why it happens, but typically we see severe bronchoria on one side when it starts, first increased secretions and rarely severe bronchoria, and in acute cases you can see an ARDS type of picture. As a result, we've changed our strategies, and like I said again, we switched to two-lung ventilation when possible to limit the amount of time we spend on one lung. Application of CPAP is another modality, and of course fully re-expanding the lung and closely monitoring the patient. And once it occurs, standard ARDS management strategies such as, I think my PowerPoint is running away from me, standard management strategies such as those for ARDS, and in refractory cases, the use of extracorporeal membrane oxygenation. So to summarize, as over the last decade, TCAB has actually matured into a very reproducible technique, which is now gaining acceptance and popularity worldwide. And as familiarity with this technique and confidence increases, we anticipate that this procedure is going to be used more and more on patients who are increasingly sick, more fragile and sicker. And this is going to, demand even more skill and, expertise on the part of a vigilant anesthesiology team. This concludes my talk. Thank you very much for your time and attention, and I'm happy to take any questions.
As you mentioned about lung isolation,
right.
A point of advice to my junior colleagues is that a lot of times we position our tubes properly, check it with the bronchoscope,
right.
but in spite of it, we the surgeons, they say that the lungs are not collapsed. And one of the tricks is that after you position your tube, please ventilate with 100% oxygen, because that is the way to denitrogenate the lungs, so when the surgeon gets access, the lungs will be properly collapsed. That is one. The second thing I wanted to say about your paravertebral blocks. This is a very nice modality for pain relief. And with ultrasound guidance, in spite of our cardiology colleagues giving them the cardiology lollipops of clopidogrel and ecosprin, you will have good access, and you can visualize the proper positioning of your paravertebral block, and it's a very good modality.
We're actually looking into that. I think it's definitely got a significant role, especially in view of the fact that most of our patients are completely fully anticoagulated. So it's a very attractive alternative to.
And use the ultrasound guidance, because it's very, very nice. We do it on a routine basis for all our cases. Because we have a very busy oncology program. In all our breast cases, they have a paravertebral block. The evening they are discharged, pain-free, very comfortable.
Yeah, we're looking into that. It's definitely a very attractive option compared to neuraxial blockade in a fully heparinized patient that we always worry about, formation of an epidural hematoma. So, we're actually looking into the use of paravertebral blocks for robotic procedures. I think it really depends with the surgeon's comfort level or I think the expertise in doing that. I mean, I think our surgeon, Dr. Bonatti, our surgeon, our experience has been, we've done about, in the last 3 years that he's been with us, we've done about almost 300 cases of robotic bypass. Out of them, almost 70% have been arrested heart and 30% have been beating heart. So I think our surgeons are pretty comfortable because of the fact that we do a lot of arrested heart TCABs, and providing a controlled surgical setting is obviously key to doing that. I think Dr. Lair would be probably the best person to answer your question, and he's actually going to follow with the next lecture, so we can.
Dr. Deshpande, if I can have one question, please.
Sure.
The question is, suppose if the patient cannot tolerate single lung, and we want to pursue the robotic surgery, what is the modality you have? Just cannot tolerate, but we have to do a robotic surgery.
Well, what we have seen that actually in such situations when we've had patients intraoperatively who've been a little unstable, we have found that when we switch to two-lung ventilation and reduce the tidal volume significantly, I think we found that of great benefit, because that combined with the increased pressures, usually creates a working field for the surgeon. Now I'm sure that it makes it a little bit difficult for beating heart, procedures, but we've actually found good use with that technique. And again, I think we have no experience with the high-frequency jet ventilation method, but I think there's a role for that. And again, it has to be done in that technique, but that group in Germany, Ender and colleagues, have actually done that in about 40 patients, I think, successfully.